Welcome again to my kitchen and to our talk about hospital care and safety. There I did my again, but today I think you're gonna meet the counselor a little bit more. I've had a little trouble getting all the kits because I'm not in a hospital at the present time, but I will get them for our next discussion. I'm ordering a central venous line kit, a catheter kit, and a dressing kit. So they'll be here, but for today, Courtney just had me do a couple deep breaths, and I'm centered. And call the dogs over, Joe.
Very
They're
nice.
right over with Courtney. Can you take a picture of them just as we start, so you know that Dr. Joe is here, and Madeline and James. So the family's all here, and Courtney. Now, when I left you the last time, I was very, very upset, you may have noticed. And it had to do with the emergency room care that my daughter-in-law received. It came out of the blue, and it bothered me a great deal. Because one of the things I truly, truly believe in is that patients in the hospital need to be treated with respect. That's a big word for me, and I can't emphasize it enough. So that when you go to an emergency room, and I'm sure the best emergencies who do this, they look at the patient and they give them the respect by listening to their history, taking a history, and doing a good physical exam. That didn't happen with Cindy, and I was trying to figure out how, why, what do you do? I'm still going to help her write the letter to the hospital because I think it's important that we react to care that isn't up to standard. The one thing you need to know is that there is a joint commission. Remember this name, Joint Commission on Accreditation of Healthcare Organizations. Put that name in your mind here. It's called JCAHO. And there are all standards of how each department in a hospital needs to be, what they need to do, what their staffing has to be, how they should treat patients as they come in. There is also material from Medicare and Medicaid. They have done an emergency department measure act. So there is background to what I'm saying about the standards of care in the emergency room. And the reason I'm bringing it up is because I talk a lot in this book, and I haven't tried to do it now, about planning. If you're going into a battle, you need a battle plan. And that's my analogy of a battle. So I think I'm going to emphasize more than even when I wrote the book on knowing the emergency rooms in your area, what the standards are, and it also involves a group of you calling the emergency room director and asking what their staffing is. Are they covered 24 hours? Come with knowledge, come with knowing about what the standards are, and make sure, because you don't want, when an emergency comes, to not know you're going to the best hospital that has a really good emergency care. Remember now, hospitals are very competitive. You may notice a lot more ads about hospitals. So use that to your advantage. Just do your homework and find out, especially if you have choice. If you don't have choice, you have one hospital, definitely go. And maybe your group, as I said before, not an individual, and find out what their standards of care and what their staffing is. Now the other thing, I look back at what Cindy told me, she never had a physical, they never took her history, which I couldn't believe. But the other thing is the staffing, and we talked about that in the beginning in the hospital, but who is it? Is it a physician that's seeing you? Is it a physician's assistant? I'd like to talk about physician's assistant just a little bit because they become more and more prominent in healthcare. I used to be very biased as a nurse, against physician's assistant. Basically thought they didn't have the education of a nurse, and I kind of discounted them. I saw them in the hospital, and they were with a orthopedic surgeon or a neurosurgeon, or usually on the surgical unit. Actually, they were very skilled because they were physician assistant, doctor trained, walking around with the physician, extremely. Since the physician's assistants have branched out into other areas of medicine, including the emergency room, I've changed my opinion of them because I've recognized that certified physician's assistant have excellent training. I asked of a physician's assistant in the emergency room I was in, remember Joe? And she told me that she had a 2-year program at our medical center. I looked up physician's assistants and I know that the University of Vermont, I'm not putting in a plug for that, but you look at their program, it's a post-baccalaureate program and it's very intense. But on the other side, I think hospitals have grabbed on to the name, the title physician's assistant. And I think the certification is what you're looking for. You want certification, not just that they've had 6 months training in the hospital. You want the highest quality of care, just like with nurses. You want the highest quality of caregiver. So that's sort of maybe it's a soapbox I'm on, but I really feel it's very important for your safety in the hospital. And you don't want it to hit you unexpectedly. The second thing I thought, what could my son and daughter-in-law say? And I think they had to note the behavior. Now that's not saying, what kind of an emergency room are you? I'm going to report you. You're not doing what I think. The statement you make, and this is the counselor saying it, you say, and actually I wrote it down, I get the feeling you don't think I should have come to the emergency room, and that frightens me. Okay, simple statement of my feelings. It's a straight eye message on the record. Now I don't know what they'll say. I can't predict that. Or they may say, oh, I'm sorry, I didn't want to give that impression, or they may just brush it off as nothing. It doesn't matter, but you need to be on the record that this is not acceptable care. So when we write the letter, which we will, I don't think Cindy's done it yet, we're going to refer to the standards of care and some of what I have just said to you. It's very important because you go through it, the next person coming along may be more vulnerable. You got to speak up. You just have to speak up. That brings me another thing about vulnerability, and this is important to me. When you go to a hospital, you're vulnerable, correct? No question about it. You are vulnerable, but you're not helpless. And the analogy I use is a soldier going into battle. They know they're vulnerable. They know it, but they're not helpless because they've been trained. They know the enemy, they have their allies. In fact, they probably, and veterans can respond to this, you wouldn't want to go in a battle situation with the soldier next to you that doesn't think there's anything to fear. You know, some hotshot that thinks I'm invulnerable, because that is going to hurt you. So the whole idea is that if you go in a hospital, you are vulnerable, but you're not helpless, and I think that's very important. The other counselor thing, and you got to stay with me because I am a counselor and a nurse. Another example I give in the book, a friend of mine was pregnant, and she was going to the hospital. She was an older lady, first baby. She was scared, definitely scared, and especially about pain. She really, the visions of women giving birth and that awful pain was too much for her to handle. So she talked to her doctor about him. He said, I'll make sure that your level of pain is okay, that you can handle it, fine. She and her husband went in the hospital middle of the night. Now stay with me, I'm going somewhere with this. And the pain got more than she could handle. And the nurses told her, I'm sorry, you're not at the right level of dilatation. You know, if anyone has had a baby, there's a certain dilatation you need to deliver. Okay, but it got worse and worse, and she was more and more upset by it. So she asked the nurses to call her doctor, which they did, and he said, give her a quart, or give her shot. She needs it. Okay, but here's what happened after that. I'm sure the nurses were upset that they were, their clinical judgment was, but that's not the bottom line. The nurse anesthetist came in, she walked in the room, and she kicked the wastebasket. Now just picture yourself. You're in the hospital, you're very vulnerable, and the nurse anesthetist that's going to give you the shot in your spine or whatever, wherever she's going to give the shot, kicks the wastebasket. What do? Don't you think she's angry? I think so. Not much you could do there except recognize you seem very angry, called in the middle of the night. Nothing you're going to do about now. And the baby was delivered successfully and everything went well. But I'm talking about respect, and I'm talking about human beings giving care who let their own emotions take over, which they shouldn't. They're professionals. So I've always stuck in my mind that this is something that is a good example of vulnerability and preparation. You couldn't have prepared for that. Who would expect that unprofessionalism? The only thing you could do, you don't want her sticking your wife. The husband was very upset, but he didn't know what to do because he was vulnerable. You don't want him getting what would it translate to? So following up on that, let's see. Make sure I've got vulnerable, not respect. Joe, how about you? What do you want to, I'm my counselor self now, and you've lived with that counselor self for so many years. How about any questions?
I'm speechless.
You're speechless? Okay, good. Actually, yeah. He'll come in with other things, but I think that's kind of my thing there. Have we got time?
7 minutes.
Well, my next thing I wanted to go was into IVs, because I did the talk on medications, and everything I said about medication, right patients, right time, right route, all apply to intravenous therapy. Now you're talking about something going in your vein, usually right here, not necessarily, sometimes into the hand, sometimes depending on the patient, I've seen it given into the foot, depends on where they can get a good vein. Okay, so that's important, depending on the condition of the patient. Most of them you see in here, and you have the bottles on. You've seen them all the time. You've seen them on TV, you've seen them in the hospital themselves. Sometimes piggyback, with one would have the antibiotic maybe, and the other, and they go in. Now you have to understand that when this is put in, it might be put into a PICC line or into something that's permanently put in the vein. It helps that they don't have to keep on sticking the person. So they put something in that has a port on it. Everything, 5 more minutes, okay, because we're going to go to another. I'll just go at the very beginning, the insertion. Now we'll just finish up on a sterile procedure, obviously. The port is wiped off with alcohol. The one thing the nurse must do is clear the line of air. So she can do it there, she can do it at the bedside. He or she, remember, run the solution down to the needle and let some of the solution go through the needle before it's inserted in the patient. This is very important. They may say that amount of air. Courtney, you said you don't want air in your vein, right?
No.
And then maybe they'll say, well, a little bit of air won't hurt you, but you shouldn't. There should not be air in the tubing before it's inserted into the patient or into the port. Okay, let's make that very clear. So that brings you to the question, what if the IV runs out? Okay, it shouldn't, because the nurse is watching it before she puts up hangs up another, not bottles anymore, but hangs up another thing. We're going to finish, let's save that, because there's so much more in intravenous, but just remember this, sterile procedure. Usually the nurse will wear gloves to do this, because you don't want anything going in the bloodstream, okay? You don't want infection. Clear the tubing, okay? So I'm going to end with that right now, and then we'll go on to other aspects of IV therapy.